I try to give you a brief update on the genetics of atrial fibrillation. I try to focus on the atrial fibrillation related outcomes. So I try to focus on stroke. I also mention briefly heart failure and also the responses to our therapy with regard to recurrences of atrial fibrillation. But before doing that, I start, of course, with the starting of the genome-wide association studies that have been done for atrial fibrillation, and there have been done a lot of work in the last 10 to 15 years. So the first locus that was discovered was in 2007, but after that there were a lot of genome-wide association studies being performed, and the list of loci associated with incident atrial fibrillation increased dramatically, and nowadays we're at approximately 100 AF loci that have been discovered. And we can explain approximately 42% of the heritability of atrial fibrillation, which is actually quite good if you compare to other phenotypes. And if you try to relate it to the total AF variants, it's approximately 10% of the total AF variants we can explain with genetics. And that's of interest because now we can start thinking about what's next, what's after all these GWAS, what can we do with this data? And I think one of the things that still needs a lot of work is that these GWAS have been of great value to implicate genes and pathways that we have not previously been have appreciated in relation to atrial fibrillation. And of course, some ion channels we know for years because our therapies work on these ion channels, but there are a lot more we have not appreciated before, and same for atrial development, for contractile and structural proteins. But this is still taking a lot of effort to go from these GWAS association, because that's what we're talking about, to really understand the mechanisms, how this causes atrial fibrillation. And of course, there has been a lot of work is ongoing, and I think a few of you are still working on these. There are very nice stories of the PITX locus, which is the locus that is the longest around. There's a very nice story with the relation with TBX5, and there are others, but there still need to be a lot of work to do. But what we can do without understanding the exact mechanisms is you can combine all the common genetic variants into a polygenic risk score and try to improve the risk prediction and risk stratification of patients with atrial fibrillation. This is a study published a few years back in Circulation. It's based on the Framingham data, and it was replicated in the UK Biobank. And interestingly, see how it works. You can see here that based on the traditional risk factors, of course, there's a gradient in lifetime risk for atrial fibrillation. The overall lifetime risk is 37%. So there's a gradient with traditional risk factors, that's what we all know for years. But if you divide patients into the polygenic risk, if you have a low polygenic risk, your lifetime risk is 30%, but it increases up to 50%. So there's a 20% extra increase in lifetime risk if you consider genetics. So that's of interest. So you can use the GWAS data to better predict atrial fibrillation and risk stratify patients based on that. Another thing you can do with polygenetic risk scores is, of course, we know that these genetic variants relate to atrial fibrillation, but they also relate to stroke as one of the major outcomes of atrial fibrillation. And there have been a few very nice papers showing this, that if your polygenetic risk score is increased, your risk of stroke, and especially cardioembolic stroke, is increased. So there is an association between the AF genetic variants and cardioembolic stroke, and it explains approximately 20% of the heritability of cardioembolic stroke, and that's completely independent of the known risk factors we have for atrial fibrillation. So there's also a role for the genetics of atrial fibrillation. And very recently, this paper was published in Circulation. It's one of, I think it's one of the first GWAS studies of heart failure that has been positive. There have been a lot of attempts in the past 10 to 15 years, but it all didn't work out because of the difficult phenotype, of course, heart failure is, we all know. The interesting thing here is this GWAS in the UK Biobank, and it was replicated in a few other very large cohorts. They identified several loci, but the interesting thing here is that the majority were linked to just well-known heart failure risk factors like coronary artery disease, and of course, for this audience here, most importantly, also to atrial fibrillation. Again, here in this GWAS, one of the top hits is the PIDX locus. So they did an additional analysis, and they found if they adjust their results for baseline atrial fibrillation, there was a marked attenuation of the association between PIDX and heart failure. And that suggests, of course, that the association they found is largely mediated by atrial fibrillation. So it's more the relation between PIDX and atrial fibrillation than it relates to heart failure itself. But it gives some interesting insights in the temporality between atrial fibrillation and heart failure, of course. So if we now move to the outcomes of the therapies we're applying, and I try to summarize it in a few slides, and there are more studies out there, but there are no GWAS studies here, and that's important to note. These are very small studies, all more candidate gene approaches. Sometimes just one gene, the PIDX gene, that's the longest around, was investigated, and sometimes a few genetic variants were studied. Here, 3 are studied. And in these small samples, they find that the PIDX locus is associated with more atrial fibrillation. But we have to consider that these sample sizes are very small, they're very heterogeneous. The procedures, of course, this is all retrospective analyses. The procedures are completely different. The follow-up is very variable. There is lack of replication, so it's at this point we cannot really rely our therapies yet or treatment decisions yet based on these results. There is a large GWAS on AF ablation ongoing. I hope it will be published this year. And there have also been similar attempts to see for other therapies, of course, we apply if we can use genetics to determine the outcome of antiarrhythmic drug therapies, because there have been some very nice experimental data that there is a relation between antiarrhythmic drugs and genetics. Also for electrical cardioversion, there have been attempts, but again, these samples are very, very small, and we really need large-scale, multi-center studies with standardized interventions and atrial fibrillation surveillance to really see if this is helpful in daily practice. So to conclude, I think GWAS hits helps us to implicate genes in cardiac development, in electrophysiology, and structural and contractile pathways, but we need more research here to understand the mechanism and to come up to drug development, because that's of course what we want with this approach. But this is something we're not yet. We're not yet there. Another thing we can do right now, and we are there, is we can use GWAS data and combine it into polygenetic risk scores to improve the AF risk prediction. I showed you a nice example that really works. So you can use genetics these days to better estimate the risk for atrial fibrillation. I think that's really an application we're now. What's also very interesting is that of course the hits related to atrial fibrillation also relate to stroke and to heart failure, and it increases our understanding of the relation between the two. Same holds, of course, for heart failure, as I mentioned. We learn more about the temporality between atrial fibrillation and heart failure. And what about the last point, the added value of using genetics into atrial fibrillation management decision? I think the ideas are very interesting, but at this point, we cannot use it yet, and we really need more research there. We need larger trials to improve our knowledge there. Thank you.